Hey, everybody. Welcome back to the Sports Docs podcast. This is Year in Review 2024, Part 2. We are so excited for the incredible year of growth that we had for our podcast. And we'd like to take a moment to say thank you to our amazing listeners, our guests, and our supporters, as well as our sponsors for making this podcast such a success. Our podcast has been downloaded in over 60 countries and is again ranked in the top sports medicine podcasts. So thank you again for everybody who's listening, and we're so excited to see what we have in store for 2025. Episode 93, Dr. Matt Provencher and Dr. Armando Vidal on strategies for multiligamentous knee surgery, recorded live at AOSSM 2024. Yeah, and in addition, we did a fair amount of varus valgus stress X-rays during my time with you and Stedman. Would you, when are you integrating that? Is that a big part of your multi-lig practice?
Yes and no. I mean, it depends how unstable the knee is, what the injury looks like. Obviously, usually we'll have the MRI and be able to assess that. So some of it is just looking overall at the overall picture and doing an initial just exam on the table, and then being able to go from there to truly say how is this going to heal. And it gets in what Armando was saying, the timing standpoint, everything. But from the initial evaluation, the other things where we've gotten a little bit in trouble, and I've seen this, is it comes in to see you a week later, 2 weeks later, DVT, blood clot. That's almost an automatic ultrasound for me. If you're more than a couple days out, ultrasound, DVT rule out. And by that point, ABIs are probably least, not as important. Maybe you still want to look at it. And then if there's any question, arterial study.
Yeah. Mm-hmm.
Yeah, totally agree. I think stress X-rays are probably better in that chronic setting. I think sometimes in the acute setting, they come in, they're so swollen,
they can't
so
tolerate.
acute. Yeah, exactly. So it's really hard to perform a stress X-ray, especially like a kneeling stress X-ray for PCL.
Yeah.
So Armando, you mentioned in terms of surgical decision making, in terms of timing, but also what you're doing. So we want to talk a little bit about timing.
Sure.
So patient comes in, and let's say that same guy that I just mentioned as an example comes in. It's isolated, purely ligamentous, so no fractures. But he has ACL, PCL, posterolateral corner. Are you taking that kind of urgently or acutely for surgery, or are you advocating for more like of a delayed reconstruction to give them time to get their motion back?
This is a great question, right? And this is like one of the big controversies right now in multi-lig, which is acute versus chronic. I think there's an advantage in that setting to get to them early because you have the capacity and the ability to repair, right? So, and that's also a controversial time, like repair or controversial topic, repair versus reconstruction. And in general, reconstruction is better outcomes. But if a repair takes successfully in restoring that anatomy, I think there's a lot of value. And you're kind of time sensitive there, right? It's probably about 3 weeks, maybe 2 to 3 weeks. So if I have the ability to get in there acutely for something that I can repair, I'm going to try to get in there acutely if I can.
So Matt, I feel like you had a counter or something you were going to add to that.
No, I totally agree, but it just gets into the surgical timing and where the patient is and how much is injured. If it's an ACL plus MCL, that's multi-lig by definition, but that's a very common scenario. It's ACL, MCL, LCL. If it's PCL plus ACL and an MCL, we're talking about a totally different scenario in terms of how to manage it. If there's something I can get after early from a repair situation, as Armando said earlier, especially in the first couple weeks, stage it. Get something repaired first, come back 4 to 6 weeks later and finish the rest of the stuff up.
Episode 107, Advances in Medial Meniscus Root Repair with Dr. Krych, Part 1.
So you published a systematic review comparing non-surgical treatment to partial medial meniscectomy and root repair. And this study demonstrated significantly improved outcomes and less joint space narrowing with repair. So based on this, are you ever treating patients non-surgically? What would push you in that direction?
Yeah, Ash, I think, would I ever? And of course, it's all about that patient in front of you. I think we'll get some into specific indications, but to me, if you have a motivated patient that has good joint space, they're probably a good candidate for repair. Now, if there is some joint space narrowing already, and they have a lot of malalignment, overweight, those sorts of things, then maybe not a great candidate for repair. And then non-operative management can be very helpful. They certainly can respond to an injection, physical therapy, I'm quick to get some of these patients in an unloader brace. I think offloading that medial compartment, can help quite a bit. We know that the natural history is for progression of arthritis, but again, if we can help treat their symptoms in the short term, non-operatively, if they're not a candidate for surgery immediately, I think they can get some benefit.
Episode 98, Dr. Rachel Frank, Concussions and Emergency Action Planning in Soccer, Part 1.
So, can you give our listeners an idea of why it's so important to recognize a concussion acutely and to remove these athletes from play?
Well, it's such a great topic, especially with upcoming football, but really year round for our athletes. Concussion is such an important thing for physicians, athletic trainers, really anyone who takes care of athletes to recognize and understand. And that's also the parents. And as you mentioned, sometimes that's the most difficult aspect, especially with our younger athletes. It's so important to recognize a concussion and then potentially hold an athlete out because of the short term, medium term, and then potentially long term ramifications. And the symptoms aren't always obvious. So that's the hard part. So you've got to be on the radar. You've got to know what to look out for and be willing, if you're the team physician or whoever's in charge of, the health and safety of the athletes, you've got to be willing to make that call because you're the one who knows about the long-term ramifications, even if in the moment people may not appreciate that. And we've seen this all the way on the professional level on mainstream media with NFL quarterbacks, as recently as the last couple of years, having repetitive concussions shown on national TV with symptoms that, in hindsight look obvious and maybe in the heat of the moment hard to detect. And then you wish you could go back and say, okay, maybe this athlete shouldn't have played. And then you see some of the short, medium, and long-term ramifications. And they can be minor, headaches, dizziness, fatigue, but there can also be major long-term implications of these injuries. And again, they're not always as obvious as a sprained ankle or a shoulder dislocation. So it's not as easy for the crowd or the parents to understand what's exactly going on.
Episode 95, Dr. Kevin Farmer on athletic shoulder injuries from the sideline to the OR, recorded live at AOSSM 2024. As far as we know from the NFL Combine data, some of the more common injuries that happen in football, so AC joint injuries, shoulder instability, as well as burners. So we're just going to really focus on those top two. But first off, starting with shoulder instability. So your initial exam, for a traumatic dislocation, is obviously done on the field, and then, maybe you're seeing them in the locker room or in the tent. But as far as if you suspect that it is dislocated, are you trying to reduce right away? Do you go in the tent? Do you go in the locker room? Do you inject? Get an X-ray first? What's your sort of method in that setting?
Yeah, ideally, if you can pinpoint it right away and have an idea that's what's going on and kind of try to pull a reduction before they get idea, they figure out what's going on.
Yeah.
I think that's helpful because their muscles aren't as tight and they're not guarding and resisting. So I've had several that have dislocated, right in front of me on the sidelines that I go there and I palpate and I feel that it's dislocated. And before they even knew what's going on, I've already kind of popped it back in. That's the ideal situation, but that doesn't always happen. And so if you get to them a little bit later and they're already kind of starting to guard, we'll go to the tent. The problem with the tent is the training tables are high. They're fairly high up, so you can't get the leverage that you can get on someone who's down on the ground. So I find it difficult to reduce a shoulder in the tent. So in that case, if you can't get it on the field, we'll often go back to the locker room, have a little more space and a little quieter environment. And again, doing it with better leverage and these kind of big muscular guys can be very helpful.
Yeah.
And then if I can't get it then the injections are always kind of the next step along the way. But kind of the order of importance, if you can get it right away, I think that's the best. And then make sure you have the setup to do it, leverage, help, assistance, all those things. And then if you can't get it that done that way, then go back in the back, take your time, kind of get what you need to do it.
Yeah. If you're looking for a trusted name in allograft transplantation and want to learn more about allograft options, then look no further than JRF Ortho. JRF Ortho is the innovative leader providing the widest array of pre-sutured tendons, including the only BTB pre-sutured tendon on the market. Plus, they were the first to offer OCA cores, available in 10 millimeters, 12 millimeters, and 16 millimeter sizes for small focal osteochondral defects. JRF Ortho also prides itself on superior customer care. making your ordering process JRF Ortho easy. They are committed to accommodating your needs, usually delivering osteochondral allografts around 30 days, all on your terms. So, if you are tired of waiting for weeks for a condyle or waiting on a back-ordered tendon, reach out to JRF Ortho to find out how you can get your allografts in a timely manner. And the most amazing thing is that JRF Ortho aims to give you one less thing to think about, so you can focus on what matters most, your patients. So, discover the only allograft company solely focused on sports medicine. Order your allografts with JRF Ortho today. Episode 96, Mastering the MPFL with Dr. Miho, Tanaka, and Dr. Beth Shubin Stein, recorded live at AOSSM 2024. So we'll move on to MPFL reconstruction. So we do want to discuss techniques, and this will be a question for both of you. And we want to get into a little bit about like graft choice, configuration, fixation, all those types of things. So Miho, go ahead if you want to work us down your algorithm.
Sure. So for me, I've actually transitioned almost entirely to the MQTFL. And I think the one thing that I would point out with this is that it's not high up on the quad. It's still really at that midpoint that we think about where the quad meets the patella. And so for this, I use allograft. I think Beth has a great reason for using allograft, so I'll save that for her explanation. And on the femoral side, I use an expanding anchor. So I like to use that because, the interference screws, I think Andreas Kamal showed that you can actually over-tighten as you're putting the screw in. So it's a loop through the quad. I stitch that to the periosteum of the supremedial patella. I'm showing this technique today in the session, and then I have an expandable anchor in the femur.
Great.
I have a different technique. I actually love the idea of the MQTFL. I think the anatomic reasons behind it make a tremendous amount of sense. And I think in the first 10 years of doing MPFLs, we saw such horrific fractures at the patella and large tunnels that the MQTFL was a wonderful idea, not just anatomic, but also spared a lot of people a lot of complications. I think at this point, in terms of knowing the risks, and the risks have gone way down. The newer studies that show the risks of fracture and the risk of complication after MPFL is much, much lower. I tend to like more rigid fixation. I do like bony fixation. So I use 2 anchors. I use it in the top, that juncture of the proximal third and the distal 2/3. I find the spot. Usually 8 to 10 millimeter bone bridge. There are 2.4 millimeter anchors, so they're very small. And the key for me, which I teach all the fellows, is stay right up against the cartilage. It's like a Bankart repair. Yeah. People are so worried that they end up getting away from the cartilage, and that's when you get into trouble with, even with anchors, you'll see a fracture if they're too anterior and there's a stress riser there. So the key is right up against the cartilage. You're almost always on the odd facet. It's not a weight-bearing portion of the cartilage. You can get right on there, and it just protects you, even with anchors, from having a stress riser and a worry about a fracture. So I use 2 anchors on the patella. I do a 2-limb graft. It goes to 1 limb on the femur. I find the isometric spot in the femur. I'm a big fan of using it anatomy first to find the sulcus, then putting a guide pin and checking isometry. And if I don't like it, I'm not even going to take an image at that point. I'm just going to change it. If it's getting tight in flexion, I'm going to move my fixation point distally. If it's loosening too early, I'll move it a little more proximally. So I think knowing that really helps. And then when I get the graft to function the way it should, which is staying fairly isometric from 0 till about 50 or 60 degrees and then loosening in deep flexion, then I just take an image just to confirm that I'm in the ballpark. And I think that has really helped, because if I see that I'm not perfect on the x-ray, but I know that it's working perfectly, I'm very happy. And to me, the key is knowing that it's loosening in flexion, because then I let the patient in fact, at the end of every case, I take a picture with the knee fully bent up and their heel against their butt to show the patients that I can get full flexion in the OR at time 0. So they can get as much range of motion as they want very quickly, which I think really has prevented a lot of stiffness.
Episode 94, Dr. Peter Millett on rotator cuff mastery, recorded live at AOSSM 2024.
Absolutely. Can you talk a little bit about, you kind of mentioned it, but in terms of the different tear patterns and how that changes your repair construct? So if you have like a massive U, or if you have an L-shaped tear, kind of what are you doing first in the surgery to make your repair easier rather than just dragging it over medially or laterally and tacking it down?
Yeah, I think the preparation is probably 90% of the surgery. Actually putting the anchors in and putting it through the tendon is the easy part. So I spent a lot of time removing all the bursa, doing all the boning work that I'm going to do, and then looking at the tear. And I always look at it from posteriorly and laterally. I usually look at it, I make 2 lateral portals, so I look at it from anterolateral and posterolateral. I put a grasper on it. I figure out where the tear goes. I try and look at the fibers of the supraspinatus and try and line them up so that they're going in the appropriate direction. I look at the infraspinatus, which usually has a little bit of a shorter tendon, make sure that that's coming around where it belongs. Sometimes the infraspinatus will really wrap all the way around the greater tuberosity. There were some studies that looked at the anatomy of that showed that. And so I really spend a lot of time understanding the tear pattern. And then once I have that figured out, then that really dictates how I'm going to repair it.
Episode 109, Dr. Patrick Denard, Treatment of Challenging Rotator Cuff Pathology, Part 1.
For the listeners, they took over 100 patients. They looked at a GNRI, which is a geriatric nutritional risk index score, which is a function of albumin and BMI. So very simple. And then they stratified patients, looked at re-tear rates. And when you do the initial analysis, well, all the normal things are there: tear size, padding penetration, right? And also the GNRI. But when you do a multivariate, in the multivariate analysis, poor nutrition, which is pretty common, their thresholds were really low, was a much bigger factor in re-tear rates. The odds ratio was 3 to 5 times, depending on how you stratified it, and tear size was only 1.1.
Thank you again for listening to this episode of the Sports Docs podcast. We truly thank you for all you've done to help our podcast grow over the last few years and look forward to 2025.